Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, Professor of Medicine and Infectious Diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Today, July 11, 2025, we are speaking with Dr. George Rutherford, a Professor Emeritus of Epidemiology, Preventive Medicine, History, and Pediatrics at the University of California, San Francisco. He's also director of the Center for Global Strategic Information and Public Health Practice in the Institute for Global Health Sciences. Dr. Rutherford's research interests are the epidemiology and prevention of infectious and tropical diseases, with a primary focus on HIV and AIDS. His research explores the epidemiology of tuberculosis in California, the prevention of childhood injury, immunizations, and bioterrorism. Today, Dr. Rutherford joins us to provide an update on the emerging infectious diseases that our world is encountering. George, welcome to the podcast.
Thank you so much for having me. It's a real pleasure.
It's great to have you. And I think we'll just kick it off by going to previous emerging infection, COVID. I interacted with you indirectly through Paul Volberding and a lot of your dialogues that you had, and they were incredibly informative. But what struck me was how on top of things you were really from the very beginning. So let's go back and just kind of review what COVID was like for you as someone who studies emerging infections. That was a pretty big one.
Yeah, I'd say, this is probably about the ninth major epidemic I've lived through during this period of my life. And yeah, it was a huge big deal. Just trying to stay abreast of what was going on, providing the best advice for the state and, immediate Bay Area counties and the University of California. It was pretty heavy lifting, as you might imagine.
So when you first got into that, we go back to say late December of 2019, early January, you start getting signals. How did you start putting it together, and what were your sources of information?
There are a number of sources of information. I tend to rely on CDC for much of it and WHO. But there are also other things. Hopkins had a wonderful website that kind of gave pretty much up to date numbers, and just what was showing up in the scientific literature. I mean, I'd have to say this is my first experience with a lot of preprints being published, which I found sort of squirrely, I guess, is one way to think about it. To start with, but then I realized you can't wait 9 months for this stuff to get printed. So I culled through that stuff pretty carefully as well, and updated things as they went. Being really in kind of global health, international health, I actually knew where Wuhan was, so stuff like that. That's kind of helpful. Because there's a lot of tech back and forth with Northern California, as you could imagine. Right. So it's, they were, just you got to get out in front of it and you got to start it at the beginning. It's hard to come in from the side. It's you want really that whole kind of arc of experience. You really need to be looking at it from the beginning.
Right. And so, you talk about the quick release of information. I had COVID or caught it in mid March of 2020, and about 5 days into my illness, the doc from France released a video on YouTube talking about hydroxychloroquine. That's how he announced his study, and I was sitting there kind of with my pulse ox dancing between 89 and 91, wondering if there's something I can do to stay out of the hospital. I'm looking at this and going, where did this come from and what is that? And so the misinformation really started pretty early in the epidemic.
Yeah, well, my new favorite quote is that the plural of anecdote is not data, right?
Right. Yes, exactly.
Um, were you did you benefit from prone positioning? Were you that? I can't remember exactly
No,
what.
I didn't try that, and I frankly didn't even know about that till I got well enough and went back to the hospital and saw that. Fortunately, I never got hospitalized.
Oh, good.
Yes, I was dancing right on the edge of it, but I just sat up and stayed up all night with my cytokine storm and watched Ozark, which would kind of match my mood. So that was a pretty good combination. Let's look back with a retrospective scope here. What do you think we got right during the COVID epidemic?
Well, as much as I think Operation Warp Speed was something that we absolutely got right. We should absolutely do it again that way. And, everybody who complains about it now, doesn't realize where we were. They've forgotten how bad it was. So I think, that the rapid development of drugs and diagnostics is important. It's hugely important, and that's what really stopped the epidemic more than anything else. I think. Now you could say, oh yeah, we naturally immunize the whole world in the Great Barrington, Declaration and stuff. That's swell as long as they're not RNA viruses, which mutate at the rate of about in every 100 replications or whatever the number is. So you can't be sitting around waiting for the population to become immune for something that changes all the time, right? So you got to have something that's a little bit more universal, and that's why the vaccines are so important. And if you look at the curves, it took a couple 3 months for it to really blunt out, but it blunted out. And for those of us in areas that were, say, more conservative in public health practice with shelter-in-place orders and things like that, like the Bay Area, you know, our surges came in October. So it was way late, way later, and it gave that lead time. Remember, the vaccine came out in December. I think that was one thing we really got right.
Yeah.
I mean, obviously, there's a lot of politics that muddied the whole waters and continue to muddy it, and they want to blame the Chinese for this and blame the Chinese for that, and yeah, they shouldn't have live markets, but there's a live market still in San Francisco, believe it or not. And you know, that's obviously screwed things up. But the other thing is that we didn't do very well is we were sort of lacked the ability to import large amounts of the diagnostic agents we needed, which if you're going to do contact tracing and things like that, which we did, you need essentially endless supplies of that stuff, along with masks and, everything, all the accoutrement. So that's another thing I think we could fix in the future.
Yeah, I think that I really resonate with your comment that we tend to forget how bad it was. I mean, the hospitals were socked in with patients.
Yeah.
New York, 97% of the patients in the hospital had COVID. The ICUs were overwhelmed. Other major cities, and it didn't look like it was going to stop. Heading into April of 2020, and if you're going to push a panic button, that's the time to do it. You got to do something because what was happening, quote unquote, naturally with no interventions was going to overwhelm the system. And I think that's what people
Yeah,
just,
and and then you have hospitals that can't do hip surgery and the stuff
oh,
that
somebody comes in with an
people
MI,
die.
there might not be a bed for them. And COVID, even if they don't have COVID, obviously. So yeah, there's a lot that we had to do. And I think the vaccine, the warp speed, was just truly miraculous. And I never could understand. I don't want to get all political here, but why why Donald Trump did not claim victory with that. He loves to claim victory with things like, bombing Iran and obliterating nuclear facilities. Really, that was an amazing accomplishment, and it
Incredible,
happened under his watch, and he
incredible.
enabled it with funding, and he should take pride in that.
Yeah.
Doesn't make sense. So, well,
And
let's
your
talk
point
about.
is, yeah.
Yeah, my point is, yeah, I think it's kind of obvious. So, what switching on to today and into the next 5 to 10 years, what are the potential emerging infections that you sort of think about, maybe even stay up at night concerned about?
Uh, well, I mean, there's kind of two areas. One is H5N1 influenza A, which is spread extensively through mammal and avian populations. There's a colony, rookeries of sea elephants in southern Argentina, where the neonatal mortality rate was 97% a couple of years ago.
Mm.
And that stuff is just, that's scary stuff, right?
Mm.
And we do have, societal experience with influenza A outbreaks from even earlier than 1918, 1919. But there's a wonderful article. There's some historians from I think they were from Harvard trying to predict which cities did better and why they did better in 1918, 1919, and St. Louis did the best. And it's because they shut things. They did essentially what we would call shelter in place early, and kept their foot on the brake. And they had to deal with politics. They let it off, and it came right back. But then they got it shut down again. And I was sitting in the director of health's office for San Francisco, and both my Berkeley equivalent Art Reingold and I brought this article up, saying, here's the roadmap right here. This is what you need to do in the absence of vaccine, the absence of therapeutics. It's all good. So anyway, H5N1 is something that I'm obviously concerned about, and if I were running the world, or if I were running CDC or HHS, probably even better, I would probably push to have a lot of people who have direct exposure to dairy cattle and big poultry operations, to get them vaccinated. We have 4.5 million doses of vaccine. Let's use it.
Mm. Yeah.
Try and cut it off at that first level rather than wait for something to go wrong and then add it. So that's one thing. The second thing are the arthropod-borne viruses. We've already seen West Nile spread all over North America and South America. But what we really haven't seen recently are dengue and chikungunya in places like California. Now, there are 40 cases of dengue in Los Angeles last year, and some of them were autochthonous. So the vectors do exist here. Mm-hmm. And I think that's another thing to be concerned about. Yes, there is a vaccine for dengue. It's the world's most complicated vaccine to use, and I don't think it's a panacea by any stretch of the imagination yet. I mean, you'll get there eventually. But chikungunya is, lifelong debility potentially. So those are things that I would be concerned about. And don't ever forget that the Virgin Islands and Puerto Rico are part of the United States, which we tend not to remember very well. Puerto Rico had a huge Zika epidemic. Now, I think, what happened to Zika? Probably naturally immunized the whole population. It's probably a relatively more stable virus.
Yeah.
Or people did backyard, abatement of standing water and things like that. I seriously somehow doubt that that's really the case. But I suspect it may just be that people became immune. And it's, there's huge consequences for that still in Brazil. They have a whole generation of kids with microcephaly
Yeah.
who are not going to do well. And yeah, there are a handful of cases in South Texas and a handful of cases in Florida, but it never really got beyond there. And but I think it's potentially a matter of time before we start seeing real transmission, especially if we dismantle the public health system and stop spraying,
Right.
stop doing larviciding.
So it feels like I'm sitting here in Alabama. There's yet another afternoon rainstorm, as if I'm living in the tropics now.
What
And
makes you think you're not living in the tropics?
we are living in the tropics. And so I think your points about arthropod uh, viruses is real. And I think this is maybe just the beginning of what we're likely to see. Let's dig in a little bit to the dengue vaccine. One of the concerns originally with that is that we know in the natural history that somebody who gets infected with one of the dengue serotypes, if they can survive that, it's a bad febrile illness. It's not fun to go through, but they usually survive. A second infection can trigger a hemorrhagic fever situation that is not as easily survived. So there was a lot of concern about priming the immune system might actually make people more susceptible to on their first infection to be getting hemorrhagic fever. Not really seeing that. I haven't heard much about that since the vaccine got released.
Yeah, I mean it's nothing I follow that closely, but it's of concern. And at least at one point in time, you were supposed to have already had it before you could get the vaccine.
Oh,
Um,
hmm,
so that was I don't know if that's still somehow part of the equation or not, but it's just imagine the logistics of that.
yeah. So, in circling back then to uh, H5N1 or the bird flu. Um, right now, we seem to be restricted to just a few cases that had kind of direct contact with an infected animal, and so
Mhm.
one-off almost. But it feels like there's just a couple mutations away from that virus suddenly becoming pathogenic and transmissible to humans. That hadn't happened yet, at least to my knowledge. But it
Transmissible from human to human. Yeah.
that allows human to human. Correct. That's thank you. And so um, we can't predict if or when that would happen. But one of the things that I think, and I'd like to kind of spend the rest of our time on this, is the damage done to public health through social media, through assassination of trusted voices, through the attack on facts that are seem pretty solid in the world of public health, the world in which you've lived for your entire career in prevention, um, and then sort of a dismantling in the last 6 months of a lot of the public health infrastructure. Um, let's talk about what ought to be there and what's not there currently that has you worried.
Sure. Well, in my direct experience, what's being dismantled is the international part of our work. With the closure of USAID and PEPFAR downscaling, and which was always bound to happen eventually. But it seems to be accelerated. And I don't know if you saw this article by Cavalcante in Lancet, but the claim was there'd be 42 million additional deaths, um, which is a lot. I mean, I can't remember how many people die in the world each year, but it's like 50 million. It's not as many as you'd think. Um, so I no, that can't be right. Anyway, whatever the number is, um, it's I think that's where we really feel it, that our expertise is not available for sharing, readily available for sharing. And it also means is that we're unable to learn from other places. So a lot of the California approaches to childhood immunization, for instance, were based on what went on in Mexico, which has a hugely successful vaccine program. So, those are problems. What's going to happen? When you get down into when you start stopping surveillance, especially for HIV, especially for underrepresented groups like, the trans population. And, it's just not, it's such selective, it's such selective memory about what's wrong with, what can go wrong with public health. We've seen the underimmunization in Texas, which in all fairness preceded Secretary Kennedy, but it's certainly kind of part of the playbook. Lead to the largest measles outbreak since the late 80s. So, there's only so much you can do with what you have. And we, at least, our group has shrunk quite a bit, but that's mostly on the international side. But I can tell you at the city health department, their groups, especially that do HIV research, have been just decimated. Serious senior investigators are now, at like 15% coverage.
Mm.
It's not where we want to be. It's not where we want to be as a society. It's not a way to be prepared. It's not a way to test out new ideas. Can we really stop HIV through a combination of long-term cabotegravir and, screening and treating people for treating the infected for HIV? I think you probably can. Now, it's hard to do in one city, and people come in and people go out, but it's still, I think it's in the cards, but we're never going to find out.
So a lot of what we need, and you alluded earlier to getting ahead of bird flu by looking at likely hotspots in advance and vaccinating, that would be a proactive move. The other thing I think we touched on as well, that I don't think we have a chance if something were to happen now, is diagnostics. That was really the Achilles heel of the beginning of our response to COVID. And you'd think that we would learn, but that playbook is put aside. And having a rapid response team of some sort at a federal level, either out of CDC or somewhere, in coordination with health departments throughout the country, um, being ready to respond, you've got to have the ability to test, track, measure, follow, all those things in real time. Else this thing gets out of whatever it is, gets out of control. And I think that's what's keeping most of the seasoned epidemiologists up at night.
I think that's totally fair. For COVID, for instance, when the city workforce, San Francisco workforce, went on shutdown, basically shelter in place, we had our pick of whom we wanted to do contact tracing for us, and we took all the librarians because they could find stuff, and a day of training later, they were out in the field knocking on doors. So it's.
Now, did they use a Dewey Decimal System to get?
I don't know. Sometimes some things you don't want to know, right? You just step away. But it was we had a choice between them and this. I shouldn't say this, but we had a choice between the librarians and the city attorney. And I said, no, let's get the librarians,
Smart.
But there's a certain kind of horsepower that you need. And paradoxically, one of the things is that we're all of a sudden public health has become a major at not only at the university level, undergraduate major, not only at the university level, but at the state college level. So San Francisco State has something like 500 majors public health. So the workforce is there
Mm-hmm.
if we want to employ them, but it takes money. The city doesn't have that kind of money. The state doesn't have that kind of money, and it's going to have to come from it's going to have to come from the federal government.
Yeah. So our time, as I sort of anticipated, has flown by. What would you like to see happen? What can we do, I guess, to maybe close some of the gap from these fairly draconian cuts that public health has had? We're going to be left with hopefully some at least basal level of people who can respond. There's certainly like enough trained people, like you just alluded to, but how do we coordinate this from the academic perspective or from working with government, local governments, to kind
Yeah,
of do the best we can under these circumstances?
it's a question. Public health is like the police, right? It's a government function, and I think it's what we work extremely closely with the San Francisco Department of Public Health, and it's almost kind of blurry who works for whom. It's less so now, but I think you have to have a really close relationship. At some of our partner institutions, they don't have no idea who the health department head is. It's like it doesn't enter into the equation. UCLA is pretty good at it, but I think we're probably the tightest of all of them, at least in California. So I think that's one real thing, is that you need to be able to help them, and they need to be able to help you. It's part of your public mission. It's part of the service mission of when you have a department that does epidemiology and biostatistics, well, okay, that's nice. It's like having a department of surgery that just trains people to work in surgical laboratories.
Mm-hmm.
You need to train practitioners. And, the more that we expose people kind of across these boundaries between government and academia, the better. And I think it serves the people a lot better to have that crossover.
Well, I think that's exactly right. And sadly, we're out of time right now, but I want to bring you back when some of this dust is settled and kind of take another stab at where we are and what we can do, because it really feels dire right now. And we haven't seen anything break just yet. But we waited 100 years for something like COVID to come to follow on from the 1920, 1918 flu epidemic. And like you said, we followed the roadmap, at least of St. Louis, that we tried to do, and now we're getting huge criticism for that. But people again forget how bad it was at the beginning of the COVID epidemic, right? So hopefully we can come out of this and we can revisit it with a little bit of hindsight in a couple, maybe a year or two, and we'll have you back and take a look at where we are.
Sounds good. Enjoy the thunderstorms.
Yeah. Thanks so much for joining us, George.
You bet. Bye-bye.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed on this podcast do not necessarily reflect the opinions of the IAS-USA and its affiliates. And the viewpoints of the individuals on this podcast do not necessarily represent the viewpoints of their institutions. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode. Thanks for listening.